So there is in this case study, we will look at a 50-year-old male presented with bone pain and pathological fracture of humerus. So are you paying attention here? See here, there is a 50-year-old male, bone pain, pathological fracture. So the bone is definitely weak. What is this? X-ray of skull shows osteolytic lesions, which appear as multiple round, discrete, punched out radiolucent areas. Definitely it looks like multiple myeloma. Laboratory findings, urine analysis, you are seeing proteins are more, could be Bence-Jones protein, because here they are saying they precipitated on heating urine at 60 degrees centigrade. So Bence-Jones proteins, hemoglobin is less, so some kind of anemic picture is also there. So what and all you saw in this now? What is the diagnosis? Write 2 points in your favor. Name other diagnostic tests for this condition. Okay, name other diagnostic tests for this condition. What is the ESR finding in this condition and give the reason. So let us look at this. So our guess is it is multiple myeloma. Let us go to our multiple myeloma PPT. Okay, and just look at this where we have already seen this in multiple myeloma. What and all we have seen, let us see. Basically here it is a malignant tumor of the bone, right? It is a tumor of the bone. Multiple lesions will be there. Bone marrow is affected. That's why it's called myelo. This is also called as plasma cell neoplasm. A lot of plasma cells will be there. It will be producing all antibodies, that is immunoglobulins. Okay, there is monoclonal proliferation of B cells. Etiology, we have seen radiation exposure, karyotypic abnormalities like 11-14, 4-14, overexpression of MYC, RAS, mutation of the tumor suppressors. Molecular pathogenesis, what exactly happens also we have explained. We saw that the plasma cell will join with the bone marrow stromal cell with this extracellular matrix proteins, and because of this adhesion, some cytokines are released like interleukin 1, then tumor necrosis factor alpha, lymphotoxin, then MIF1 alpha, that is macrophage inhibitory factor, rank ligand, etc. Now because of all this, what will happen? There will be osteolysis, there will be osteoclast activating factor, so there will be bone destruction. So this guy has pathological fractures and what? He has bone pain, correct? Now coming to interleukin 6, this also is released by that adhesion. It is going to activate the cyclin D pathways, P21 cell pathway is going to be activated, cell cycle pathway. So lot of B cell proliferation will happen and these tumor cells will also survive, okay, because the tumor suppressors are suppressed and there is lot of RAS and MYC is overexpressed. What is the consequences? Because of bone, there will be pathological fractures and a lot of amyloidosis will be there. Bence-Jones protein excretion in urine will happen. Then in the skeletal system, lot of places it will be scattered. Seen in elderly, so in this patient in this case study, you remember it was a 50-year-old male. So pathological fractures he'll have, pain, bone pain. Then what else? Osseous lesions, bone marrow lesions will be there. This is what they said, punched out lesions. In the radiograph, you can see punched out lesions of the skull. Correct? Then osteoporosis. There will be 1 to 2 centimeter sized defects. Such big defects will be there. Then coming to microscopy, you will see that bone marrow is hypercellular. The myeloma cells are more. You can see here, we have explained here. The plasma cells, the myeloma cells are more. The plasma cells will become such that there will be binucleate, also multinucleate cells will be there. There will be cytoplasmic vacuoles, nucleolus is prominent, etc. Right? So plasma cells only are more. So what will you see here? The 10%, greater than or equal to 10% of the marrow cellularity will be myeloma cells. Myeloma cells will be more than 10% of the marrow cellularity. Okay, if it is less than 10%, it will be something else. But if it's greater than 10%, then only it is multiple myeloma. Extraosseous lesions will be there. Like ESR is high. Atypical, because of atypical plasma cells, normocytic normochronic anemia. This is anemia is there, but it is normocytic normochromic. That means the RBCs are perfect shape and perfect color. The size is also perfect. Now there will be atypical plasma cells even in the blood. There is Rolex formation. Hyperviscosity of the blood, elevated ESR. Because of this hyperviscosity, because of red cells having Rolex formation, there will be elevated ESR. Then there will be some triad marrow plasmacytosis greater than or equal to 10%. Radiolytic evidence, we saw the punched out lesions. Guys, are you sleeping? Is it going into your head? Wake up, wake up. Let's go back to multiple myeloma. We are just taking a recap of our own multiple myeloma slides. Tumor markers, you will have immunoglobulins, Bence-Jones proteins. Remember, this is a tumor of bone. Okay. I think that's enough. We have given you a lot of information. Going back to the case, now you'll be easily able to answer this. So a 50-year-old male presented with bone pain and pathological fracture of the humerus. X-ray of the skull shows punched out radiolucent areas. Laboratory findings, you have urine analysis. Proteins are high hemoglobin. They have not mentioned here, but definitely it will be a normocytic, normochromic kind of an anemia. What is the diagnosis? Look at the bone marrow picture. What is the bone marrow picture telling you? Bone marrow picture is telling that lot of plasma cells. These are all plasma cells, right? Lot of plasma cells are there. Right? All these blue ones. What do you think these purple ones are? So, lot of these plasma cells are there. Okay. Do you see anything else? So, what is the diagnosis? Write 2 points in the favor. So, let us write it now. Diagnosis is multiple myeloma. 2 points in favor. X-ray, punched out lesions. Then Bence-Jones proteins. Okay. Bone pain, pathological fracture. Fractures also you can mention. Some issue with the bone. Then what are the diagnostic tests? Tests will be, you can check for the Bence-Jones proteins, which they have already given. So what else can you mention? Serum electrophoresis. You should be able to see the M band, the immunoglobulins, gamma globulins. Then what is the other test? Go back and see whatever was the other test. Tumor markers, you can see immunoglobulins, Bence-Jones protein, serum electrophoresis, you saw this M band. Then Bence-Jones proteins, you'll do urine analysis, but they've already given that. So if you tell the same thing, it won't be right. Bone marrow picture also they have only given. Then what will you test for? Everything they only gave. Other 2 diagnostic tests they are asking for this condition. What are the other 2 diagnostic tests? Serum electrophoresis, tumor markers. Tumor markers are immunoglobulins. Bence-Jones proteins, same thing. More than 3 gram per deciliter of serum immunoglobulins. ESR also they only have mentioned. Arre baapre. ESR raised. You can say ESR raised because the third question is ESR. What is the ESR finding in this condition? Give the reason. ESR is high. Why then all, as of now we cannot say. ESR is high because there is hyperviscosity of blood. There is RBCs will have Rowlex formation. They are all clumping together, possibly because of atypical myeloma cells, plasma cells being present in the blood picture also. Okay. What is normal ESR? Guys, this ESR, right, you can do either Vestigrin method or Wintrob method. So, which one do they usually do? Let us say Vestigrin method they are doing 3 to 7 millimeter in first hour. 3 to 7 millimeter in first hour. Just remember this, okay? 3 to 7 millimeter in first hour. Here, the ESR will be high, they are saying. That means it will fall faster, right? Instead of, let's say 6 millimeter per hour, it is high. That means it will fall around, let's say 10 millimeter per hour. Now, why is it falling? Because of hypercoagulability of the blood. Even in infections, this can be more, okay? They can ask all these questions. So, what are the other causes for increased ESR? Increased ESR, other causes can be tuberculosis, etc. Okay. That's all we want to cover in this video. Case study is done on multiple myeloma. Bye-bye.